Now, the truth is that we don't fully understand the transmission of this disease, and we don't fully understand the transmission of other respiratory viruses either. So it's important we talk about that first. I'm going to talk about the lack of evidence for asymptomatic transmission, and then the importance of hospital spread. Now, all of the modelling has been done on the basis that SARS-CoV-2 spreads like measles. Measles spreads person to person. There's a continuous chain of transmission that happens throughout the year, and somebody who's infected will go into an environment, home or school, where there are susceptible people who will then catch it, and you will have more secondary cases than that primary case. An alternative model would be influenza. Now, we don't fully understand influenza. It does spread person to person. There is evidence of that, but it's not the whole story, because in influenza, it disappears over the summer, and then it comes back in winter as a surge. And those surges happen at the same latitudes across the world, simultaneously with the same genetic profile. And that can't be explained by person-to-person transmission, and it happened well before we had international travel the way we do now. And with influenza, the primary case does not result in a huge number of secondary cases in the household the way it does with measles. We know it's spread through aerosols. And in fact, in winter, in indoor environments, after an hour, you will have had an infective dose of influenza if you're in a public indoor environment. So it's not about the environment, it's about the susceptibility of the person who's in that environment. And what we've also seen for hundreds of years is that people who are out at sea with no contact with anyone else can have outbreaks of influenza. So what's the evidence for COVID? Well, we have seen these surges, which cannot be entirely accounted for by behavioural change. With the measles model, when you reduce restrictions, there should be a rebound in infections. And in the summer in the UK, we didn't see that. With the V celebrations, the Pat Beaches, the marches, there was no rebound. And more recently in the USA, we had Biden calling the governors of Texas and Mississippi's Neanderthals when they released all their restrictions, and there was no negative consequence, and the trajectory continued as it did for all the states that had strict restrictions throughout. COVID has low household transmission, like influenza. Only about 8 to 15% of contacts end up catching it. Like influenza, we had an Argentinian fishing vessel where everybody tested negative before they set sail, and 35 days later, there was an outbreak of COVID. Like influenza, COVID spreads through aerosols. We've seen quarantine hotels where patients have caught the same genetic virus as somebody elsewhere in the hotel that they have never met. We've seen it filling the air filtration systems of hospitals. And not with SARS-CoV-2, but with other coronaviruses, people have taken air and managed to grow virus in cell culture 10 miles away from where there were infected farm animals. Now, Canada have been quite open with their data. They've shared data on test and tracing, which shows that they only found a source of infection in half of their patients. And that was true during their winter peak, but it was actually also true recently when case numbers have not been very high. And it's been true despite lockdowns. So lockdowns do reduce human contact. And what you can see in this top graph is data from emergency attendances in the top graph is for gastroenteritis. So we have the beginning of 2020 up until now. And the blue line shows the global mobility data. So as people locked down and as mobility increased, the correlation with gastroenteritis cases is really, really tight. Now, you wouldn't expect that to be an epidemic-type spread, but you can see that it did have an impact on that disease up until recently. COVID's in the bottom graph, and you see that as we increased mobility in the summer, there was no rebound. We didn't have much change in mobility and then saw a rebound. So we don't have the relationship in the same way. Why are we told that behavior is what's driving spread? The evidence does not support that, and this measles model has failed. Now, is there anything else we could learn from influenza? Well, I think there might be. I think we need to look back to 1957. There was a novel flu virus, and there was huge concern because it was believed that everybody was going to be susceptible. And then they had a bad winter that year. At the end of it, they tested people to see who had had an infection, and 8% of the population had antibodies. It then went away for the summer. And then it came back as a variant the following winter, and another 7% developed antibodies, and so on. Not every single year, there's some years it missed out, but it was 11 seasons before it was done. So was it a coincidence that in May 2020, 7% of us had antibodies to COVID, or is that actually exactly what we should have expected based on influenza? Now, some people who avoided that first pass and weren't susceptible then seem to have become susceptible later. And it seems to me that you could put a hypothesis that this susceptibility will stretch over years. And it's quite unreasonable to take a decade's worth of susceptibility and assume it's all going to come at once, but that is what was done. Now, I think we're all familiar with this assertion from the government that 1 in 3 of us had no symptoms but were passing it on. And there really is no evidence to support that. Healthy people can and have tested positive. They could have been immune, it could have been a testing error. And evidence of positivity is not evidence of spreading a disease. So these studies that have been done, which show a percentage of people have no symptoms, have shown really different figures. Some studies showed 4% had no symptoms, and it's gone right up to 76%. Now, a range that big makes no sense. If you were measuring a symptom like a cough, you'd expect a constant percentage. What you're actually seeing there is not a function of the disease, it's a function of the testing. The more tests you do, the more asymptomatic positives you find. So where's the evidence of asymptomatic spread? Well, what people tend to reference are modelling studies. Now, what these modelling studies do is they make an assumption that asymptomatic spread occurs. They then do lots of complicated mathematics and make beautiful graphs which show the effect that that would have on an epidemic, and they conclude that it's really important. But the whole thing is a fairy tale based on that initial assumption that it occurs. Where's the real-world evidence that it occurs? So there are reports in the literature of it having occurred. Now, a lot of these reports are of people who have tested positive with no symptoms, having been in contact with someone else who tested positive with no symptoms. And that is being described as the transmission of a disease. There are a couple of situations where people had symptoms. There was a mum with a runny nose for a day. There was a baby with a cough. But there are no cases of a severe acute respiratory syndrome or a pneumonia or somebody needing medical care because they caught it from somebody who had no symptoms. Let's just talk briefly about hospital transmission. This graph shows patients in English hospitals across the winter. In red, you see patients with COVID. In black, no COVID. And in green, here are the empty beds. Now, the empty beds were pretty constant. So were these non-COVID patients kindly clearing the way to make room for the COVID patients? Well, no. And SAGE have included in their report an estimate that in spring 2020, there could have been 40% transmission through hospitals. And this is what we saw with SARS-1 and with MERS. So focusing on the community, on pubs and on schools, is detracting from this. And this is really important. We could do something about this. NHS has been below capacity throughout, but ITU capacity was exceeded in spring and in winter. And it does seem that COVID produces higher morbidity. So people are more sick with COVID than they are with respiratory viruses from previous winters. But it's worth bearing in mind that the UK has less than half the ITU capacity per head of the USA and Germany. So we could be acting on this. We could be increasing our ITU capacity. We could be sorting out air filtering in hospitals, putting UVC into the filtering systems. So overall, we do not fully understand transmission of respiratory viruses, and we need some humility about that. Policy's been based on assumptions around transmission that the evidence does not support, and we could be acting now to improve ventilation and ITU capacity and stop pretending that lockdowns can affect a virus that is spread through the air.